السلام عليكم.
وعليكم السلام.
آه صوتي واضح؟
واضح دكتورة.
تمام. Good evening, everyone. I'm Dr. Rahaf Alturkistani, a board certified dermatologist and inflammatory skin disease fellow at University of Toronto. I'm really happy to be with you today. In this session, we're going to discuss the hair loss disorders and nail disorder. We will go through the most important hair and nail disorder, focusing on the key clinical signs that help us to differentiate the condition quickly, recognize red flags, and choose the right management. So my goal is to keep the lecture practical, clear, and useful for your daily practice. And I hope you enjoy the session, and I look forward to learning together. So these are the learning objectives. Okay, so to start with, we're going to start with briefly about the anatomy of the hair follicle. Hair is the primary characteristic of mammals and can be found everywhere in the human body except the glabrous skin, as we all know, such as palm soles, glans penis, clitoris, and labia minora. So usually the follicles develop during fetal skin development, and we can classify the hair follicle into two parts: the vertical section and the horizontal section. As we can see here, the vertical section, which is subdivided into four major areas: infundibulum and isthmus, which is permanent areas; suprabulbar and bulbar area, where we can find the stem cell. And other classification for the hair follicle, which is the horizontal classification from the outside to inside, starting with the outer root sheath, then the inner root sheath, companion layer, then Henle-Huxley cuticle, hair shaft, and cortex, and hair middle. Just a brief note about the hair shaft or hair follicle anatomy, so we can start our lecture. Okay, so alopecia subtype. As we all know, alopecia is one of the very common cases that we face on a daily basis in our clinic, and especially, let's say, in females. We can classify hair loss or alopecia into two parts: diffuse and focal. The diffuse depend on the exact cause, but most of them are related to the abnormality of the hair cycle. The focal can be further classified into non-scarring and scarring. The non-scarring, which mainly related to trichotillomania, for example, traction alopecia, alopecia areata, while the scarring can be classified according to the cell that we can find it in the histopathology, either lymphocytic, neutrophilic, or mixed. طبعا هذه بس بريف بسيطة عن ال types of alopecia, بس we're going to discuss every one individually. So to start with the non-scarring hair loss. Androgenetic alopecia. So androgenetic alopecia, it's an androgen-dependent disorder characterized by the conversion of scalp terminal hair into miniaturized vellus hair. Can be found around 80% in men and 50% women. The frequency and severity, of course, increases with age. Okay, so the pathogenesis mainly related to a strong genetic predisposition, as we can see abnormality in the androgen receptor in men, while abnormality in WNT10A gene in men and women. While hormonal factors considered to be the main cause for androgenetic alopecia, dihydrotestosterone plays a central role in the pathogenesis of androgenetic alopecia. So serve as a trigger for hair follicle miniaturization, which means testosterone is converted by dihydrotestosterone through the enzyme 5-alpha reductase. And dihydrotestosterone does not directly miniaturize the hair follicle, but serve as a co-mediator for hair sheath thickening, follicular fibrosis, and calcification. All of these will result in a restriction of the follicle growth, a restriction of the oxygenation and nutrient supply. So what we will find at the end, there is increased activity of dihydrotestosterone in balding scalp. To keep in mind, normal level of testosterone we can find in both genders. These are the types of 5-alpha reductase. Type 1 can be found primarily in sebaceous gland and liver. Type 2, most importantly, found in prostate mainly and hair in a root sheath. Type 3, found through epidermis and derms. Just to keep in mind, the genetic absence of type 2 5-alpha reductase prevent the development of male androgenetic alopecia. Okay, the clinical feature. So in both men and women, the most common presentation is progressive, non-synchronized hair miniaturization. So the end stage of hair miniaturization is the development of vellus hair. So because of the vellus hair is thin, short, and hypopigmented, they are nearly invisible in clinical examination. So the male pattern hair loss, usually, as I mentioned, symmetric progressive recession, begin in the frontotemporal area of the hairline. Then we can find a diffuse thinning over the crown. And it really men develop female patterned hair loss. And this is the Hamilton-Norwood classification that we usually use on our clinic to classify the hair loss or the male pattern hair loss. What about the female pattern hair loss? So female pattern hair loss, it starts as a diffuse central thinning, as we can see here, of the scalp with preservation of frontal hairline. It reach until it become as Christmas tree pattern. Around 10% develop male pattern hair loss. Regarding the female pattern hair loss, we have two scales: the Sinclair scale for female pattern, which consists of 5 stages, and Ludwig classification, which consists of 3 stages. Okay, so for diagnosis, basically it's clinically straightforward. Trichoscopy might help. We can find predominance of follicular units and yellow dots, which is highly yield in exam questions. In patient actually with androgenetic alopecia, and in the absence of signs and symptoms of hyperandrogenism, authors does not perform screening laboratory tests. However, some experts routinely order screening blood tests such as dihydrotestosterone, total and free testosterone. And rarely a biopsy is done. Okay, so in histopathology, as I mentioned, rarely biopsy is done, but if it was done, we can find increased number of vellus hair, which is the main pathophysiology in androgenetic alopecia, and there is normal total number of follicles and no significant inflammation. So we can differentiate it from the other type of scarring alopecia. Okay, so regarding the treatment can be classified into topicals, oral, sprays, and even injectable. So let's talk about the treatment. First of all, the minoxidil. Minoxidil, the topical minoxidil, 2% solution, 5% solution, and 5% foam. The mechanism of action of minoxidil, it prolongs the anagen phase of hair follicle, shorten the telogen phase, and induce the enlargement of miniaturized follicle. So contribute to the conversion of miniaturized hair to terminal hair as it was before. So usually after the use of minoxidil, patients can experience paradoxical worsening of hair loss, especially in the first 3 to 6 weeks after initiation of treatment. For minoxidil, we cannot say that therapy or the treatment is failed until the patient complete 4 months. Then we can check any visible effect. So at least 12 months prior to concluding inefficacy. This is for topical minoxidil. Also, we have low dose of oral minoxidil can be given for men and women, starting from 0.6 up to 5 milligram daily in men, and 0.6 up to 2.5 milligram daily for men. Just not to forget to mention, minoxidil is an FDA-approved treatment for androgenetic alopecia. For the side effect, patients might experience scalp dryness, irritation, periorbital edema, allergic contact dermatitis, facial hypertrichosis, especially in female using a 5% solution or foam, and less than 1 out of 1,000 patients experience tachycardia and decreased blood pressure. Okay, second line of treatment is finasteride and dutasteride, and we're going to discuss both of them. Finasteride. So it's a type 2 5 alpha reductase inhibitor, oral or spray form. It stops the hair loss around 90% of patients. The dose usually is 1 milligram daily in male pattern hair loss and 2.5 in female pattern hair loss. Side effects, it has multiple sexual side effects, which occur usually can be found in men. And just to keep in mind, if the patient was on finasteride, as it lowers the serum concentration of PCA. So it's recommended to adjust the measure serum PCA, especially if we were screening for the purpose of prostate cancer. The dutasteride. So the dutasteride, it's a type 2 and type 1 and type 2 5 alpha reductase. بعكس or in the opposite of finasteride, which was only the type 2 5 alpha reductase inhibitor. Again, there is an oral intralesional topical formulation. It's more effective than finasteride. And the issue with dutasteride is it has a prolonged half-life, so we cannot use it in women with the childbearing age. Spironolactone, it's an aldosterone antagonist, also can be used as it competitively blocks the androgen receptor, which inhibit the androgen synthesis. And we can begin a lower dose around 50 milligram per day. Then we can increase it 50 milligram monthly as patient tolerate. Of course, female should be on contraception while using it, as it increases the risk of feminization of male fetuses. As we can see here, this is the mechanism of action of anti-androgen and 5-alpha reductase inhibitor. Here, as we can see, the finasteride and dutasteride, which block the 5-alpha reductase, thus block the conversion of testosterone to dihydrotestosterone. While the anti-androgens, such as spironolactone, it competitively block the androgen receptor. Again, that that will bind with dihydrotestosterone, so stop the binding of the dihydrotestosterone to the active androgen receptor. So other methods of treatment, surgical hair replacement, such hair transplantation, PRP, Regenerate, exosomes, ACell, all of these are non-FDA approved, but it shows a promising result in patients with androgenetic alopecia. Okay, so let's move now to telogen effluvium. So before we start the talk about telogen effluvium, we have to understand the normal hair cycle. In normal scalp, usually we have 100,000 of hair follicle. 90% of these follicle present in the anagen phase, which is known as growing phase. The anagen, it takes usually from 2 to 4 years. Then 1% of the anagen hair follicles enter the catagen, which is the transition phase, and 10% of these hair follicle enter the telogen, which is the resting phase. Usually, telogen, it takes 3 months. After then, the hair will go into exogen, which is known the shedding phase. So daily, around 50 to 200, about 200 hair follicles are shed. So just to keep in mind, we have to understand this hair cycle so we can understand the other disorders of hair loss. So the pathogenesis. There is multiple internal or external factors that interfere with this normal hair cycle, which can trigger telogen effluvium. Most common disturbance is shortened anagen phase. Basically, the hair follicle does not take enough time in the growing phase and enter the catagen, telogen, and exogen quickly. So the transition begins the hair shedding process, which eventuate clinically represent hair loss, telogen effluvium, which means that telogen effluvium start to occur 3 months after the inciting cause. It's important to keep this period in your mind because we have anagen effluvium, which usually start 2 weeks after the inciting cause. So these are the main triggers for telogen effluvium. Most importantly, shedding of the newborn, pregnancy, fever, infection, any illnesses such as hyper or hypothyroidism, systemic diseases, strict diet or with post-bariatric surgery, any procedures, medication, for example, discontinuation of oral contraception, Sometimes patient on isotretinoin may also experience telogen effluvium at the beginning of the treatment, anticonvulsant, beta blocker, and of course, any psychological stress. So clinical feature. Clinical feature, thinning of hair involve the entire scalp. Basically, what we face on a daily basis in our clinic, I have severe hair loss. That's the common symptoms or complaint that we face in our clinic. So how we can diagnose telogen effluvium? So hair pull test is one of a test that should be done, and the patient shouldn't take a shower for 24 to 48 hours. Then when we pull the hair, it will be positive if there is 2 or more hair follicles. Trichogram also might show a mixture of anagen and telogen hair. Trichoscopy is often diagnosed as exclusion. So, as I mentioned, it's a diagnosis of exclusion, or we can say can be diagnosed based on history. So, no need for a scalp biopsy. But if it was done, we can see increase in the telogen count up to 20% or 15%, which is basically suggestive. There is normal total number of hair and normal number of terminal hair. So when the cause is unclear and patient is not on medication, does not have any stress, he was not admitted, for example, in the hospital, no any surgical procedure or any illnesses. So evaluation of the patient includes, we can order thyroid function test, chemistry panel, CBC, vitamin D, B12, and ferritin. And ferritin level should be more than 40 nanogram per deciliter. And this is the visual shedding scale. We can show it to each patient. As we can see here, number 5 and 6 is considered abnormal or suggestive of telogen effluvium. Treatment. Main treatment for telogen effluvium is reassurance. Discontinue any potential offending drugs or medication, exclude other causes. We can start with iron replacement if the serum ferritin was less than 40. A topical or low dose of oral minoxidil might help, but it's an off-label and not FDA approved. PRP as a plasma can be also done, and prognosis is excellent if what was associated with systemic disease and the systemic disease was treated. Okay, trichotillomania. So trichotillomania is one of the OCDs, or it's a hair pulling impulse control disorder. Usually begin in the early childhood or adolescence, more common in female. It's commonly related to other disorder, which is associated with compulsive hair cutting or shaving. Clinical feature is very important. Usually, we can notice usually notice the black scalp hair result in patchy areas of alopecia with different hair lengths. And some patients may also have trichotillomania association not only in the scalp, but also in the eyebrows, eyelashes, extremities, and pubic region. As we can see, it has an irregular border. Some erosions and crustation also can be found, and again, hair of varying lengths. Most of the patients, the occipital part tend to be spared. Okay, so this is a very high yield for exam purposes. There are 7 signs with high specificity on trichoscopy in patient with trichotillomania. To start with, we can see as here the V-shape hair. Then we can see also the coiled hair, as we can see here. And this one, the tulip hair, then a flame hair powder, trichopitilosis, which is splitted hair ends, and hook hair. So these 7 signs with high specificity for trichotillomania can be seen by a trichoscopy or dermoscopy. 2 signs are not specific, such as broken hair and black dots, which can be found in any other non-scarring or scarring, even alopecia. Treatment. So there is no specific treatment approach can be used in those patients. Behavioral modification therapy and habit reversal training considered the first line. Other first-line pharmacological therapy can be used, clomipramine and N-acetylcysteine, which has recent studies for their effectiveness in the treatment of trichotillomania. Okay, so alopecia areata. Alopecia areata is considered one of the very common autoimmune-mediated disease that we face also in our clinic on a daily basis. Most commonly, it affects the scalp, but also can involve other areas. And patients with alopecia areata, since it's an autoimmune disease, they have increased risk of other autoimmune disease, most commonly thyroid disease, atopic dermatitis, vitiligo, and SLE. The pathogenesis. So there are multiple hypotheses regarding the pathogenesis of alopecia areata. Most importantly, and to keep in mind that it's a T-cell mediated disease, which means T helper 1, interferon gamma, lead to stimulation of CD8 cells. These CD8 cells infiltrate and affect the hair follicle, result in upregulation of MHC or the major histocompatibility complex, which result in loss of hair follicle or the immune privilege of hair follicle. Also, we can find there is upregulation or increased interleukin 15. And to keep in mind, interleukin 15 and interferon gamma are dependent on the JAK-STAT pathway. JAK-STAT pathway, why I'm mentioning this? Because there is many FDA-approved medication that are considered as a JAK inhibitors and involved in the pathogenesis of alopecia. Other environmental factors such as viral infection also in genetic susceptible patient may also lead to T-cell driven autoimmunity. يعني هذه كده باختصار الباثوgenesis of alopecia areata. It's important to know that it's a CD8 mediated effector T cell. So clinical feature. So the classic presentation of alopecia areata present as round or over patches of non-scarring alopecic patch and the scalp mainly. Other presentation, alopecia totalis, which mean loss of all scalp hair. Universalis, loss of scalp hair and body. Ophiasis pattern, which is band-like pattern of hair loss along the periphery. It involves the temporal and occipital part. Sisafo, another synonym ليها اللي هي الophiasis inversa, which is the opposite of ophiasis. It's a band-like but spare the temporal and occipital area. Reticular variant, it's a patchy form of alopecia areata, where you can see once one alopecic patch grows, the other one regrow. So hair loss in alopecia areata is generally reversible, and the hair or newly growing hair is usually gray and white. So it's important also to know what are the poor prognostic factor in patients with alopecia areata, and it's an important and a high yield exam question. Poor prognostic factor, alopecia areata in childhood, if it was diffuse, if it was chronic more than 5 years, if there is a nail involvement, ophiasis pattern, and if it was associated with atopy. The most common nail abnormality is nail pitting, and we will discuss it in the nail disorder section. Other changes, what we can find, trachonychia, onycholysis, brittle nails, coloonychia, and rarely onychomatosis. But most common is nail pitting. This is the alopecia universalis and totalis, complete loss of the scalp and complete loss of scalp and body hair. This is the ophiasis pattern, which is a band-like, involved the occipital and temporal part. Sisafo is the opposite of ophiasis. It involves loss a band-like, but in the frontotemporal part, and spare the occipital and temporal part. This is the reticular variant, areas of alopecia, while the old areas just had a hairy growth. Nail finding as nail pitting and trachonychia. Trichoscopy feature. So one of the common signs that we can find in patients with alopecia areata is the presence of exclamation mark. But again, exclamation mark is not specific in alopecia areata, can also be found in trichotillomania. As we can see here in the picture, we can see multiple exclamation mark. That's what we call it, exclamation mark. These are black dots, and some are yellow dots as we can see here also. And number C is where we can, this considered the regrowth phase, as we can see fine hair follicles emerging, and also yellow dots. Histopathology, although alopecia areata, it's not mandatory to do scalp biopsy in patients with alopecia areata, but it's important to know the features of histopathology. Mainly that there is normal number of hair follicles, and there is mononuclear infiltrate around the bulb, especially the lymphocyte and occasionally eosinophil. Other synonym we call it for those patients, it's swarm of bees, that there is multiple lymphocytes around the peribulbar area. Not to forget to mention also pigment cast and intracromalacia. It's an important also finding in the histopathology. Treatment. So there is multiple off-label and FDA-approved successful topical intralesional systemic therapies. The therapy depends actually on the age, extent of disease, and patient expectation. To start with topical intralesional, first-line topical therapy is ultra-potent class 1 corticosteroid. Other topical can be used, such as prostaglandin analog, especially in the eyelashes and eyebrows. Children with the severe alopecia, we can offer immunotherapies such as DPCP. To be honest, the result is not promising. And if it was solitary patch, we can offer intralesional triamcinolone around 2.5 to 5 milligram every 3 to 4 weeks in both children and adults. Systemic, high-dose systemic steroid can be used either pulse on a pulse dose or on daily basis or weekly basis. The issue is that with 50% will relapse with dose reduction or discontinuation. So it's recommended to start other steroid-sparing agent with a steroid or as a monotherapy such as MTX or cyclosporin. Oral JAK inhibitors, what we are using nowadays, the baricitinib, it's an FDA approved above 18 years old, breticetinib above 12 years old, and deroxacitinib above 18 years old. All of them are FDA approved for the treatment of alopecia areata. Okay, so anagen effluvium. So there is sudden onset loss of anagen hair within 2 weeks or after 2 weeks of the inciting cause. As you remember, when we mentioned telogen effluvium, it starts 3 months after the trigger, and the anagen effluvium starts 2 weeks after the trigger. Usually, it's related to chemotherapy, radiations, chemicals, or severe protein deficiency. And anagen effluvium, what I want you to focus on is the trichoscopy, as we can find something called Paul Pincus construction along the hair shaft. As you can see here, it's a construction in between or over the hair shaft in the same hair follicle, and this is characteristic and seen in anagen effluvium secondary to toxic insult. Treatment, discontinuation or avoidance of the causative factor. Scalp cooling also can be considered, especially in patients who are on chemotherapy. Pressure-induced alopecia, it occurs following prolonged embolization, especially in those patients after surgical procedure or admitted to ICU in a supine position with a head fixed in one position, usually occurs in the occiput. It's reversible and associated with complete hair regrowth. Temporal triangular alopecia. It's also known as congenital triangular alopecia. There is a triangular hair patch, usually unilateral or bilateral, can be found at birth or first decade of life. The issue with temporal triangular alopecia, it's persistent for life. Okay, so traction alopecia. So traction alopecia usually occurs as a result of repetitive and prolonged tension in scalp hair, usually after styling the hair with heavy braids, ponytails, and wearing turbans. Usually observed in the frontal and temporal area. And treatment for those patients can be done with topical or oral minoxidil, steroids, and or even oral antibiotic. Not forget to mention the French sign, which is a very important sign in patients with traction alopecia. As you can see, thin stripe of hair retained in the original frontotemporal area, separated from the hair-bearing margin by 1 to 2 hairless patch. This is known as French sign. It's also high yield for exam. Lipodermatous scalp and lipodermatous alopecia. It's a disease related to lymphatic dilatation, which result into a spongy scalp. As you press your finger, you can see a depression. It's not very common, but you have to keep it in mind, as you can be asked also in the exam about it. The treatment, ultra potent steroid should be enough. Okay, so we are done from the non-scarring alopecia. Don't worry, we will have a quick revision after we are done with the hair loss disorder. I know it's a huge topic. Let's start with the scarring hair loss. So, scarring alopecia, it's a group of a disorder with inflammatory process that lead to permanent destruction of the hair follicle stem cell, mainly the bulge, with the subsequent replacement with fibrous tissue. Can be primary or secondary. The primary, the follicle itself destroyed by inflammatory process. The secondary, follicle is innocent bystander, which means there is multiple factors that affect the follicle. For example, burn, radiation dermatitis, malignancies, infections such as TB, sarcoidosis, morphia, all of these considered secondary causes for cicatricial alopecia. So, the scarring alopecia, few hair disease demonstrate biphasic pattern, which means it can start as non-scarring and then become scarring. For example, androgenetic alopecia, alopecia areata, and traction alopecia. If it was chronic and left untreated, it's non-scarring, then become scarring. Most of these diseases overlap clinically and histopathologically. And then lastly, scarring alopecia can be classified into lymphocytic, neutrophilic, and mixed, according to the cell that we can find in histopathology. So how we can diagnose scarring alopecia? So diagnostic tools, dermoscopy can be done, scalp biopsy, but just to keep in mind, scalp biopsy, we have to take two specimens, one vertical and one horizontal for appropriate diagnosis. Hovid technique is one of the very common techniques that use for cutting the specimen or the scalp biopsy, as we can see here in the picture. طبعا هنا الvertical الhorizontal والvertical section. Okay, so these are the classification of primary cicatricial alopecia, as I mentioned, lymphocytic, neutrophilic, and mixed. Let's start with the lymphocytic. So lymphocytic, central centrifugal alopecia. Most commonly can be found in Black patients, female, who use chemical hair relaxers, pomades, and usually due to hair styling. It can be associated with PADI3 mutation. It begins in the vertex or the crown and expands centrifugally. Usually it's asymptomatic. Of course, in a trichoscopy, tufted hair or polytrachea can be seen, and then we will find what's at the end of the lecture, what are the differential diagnoses of tufted hair or polytrachea, as it's not specific for central centrifugal alopecia. In certain cases, in addition to hair loss, we can find some pustules and crustation, which might suggest secondary bacterial infection. Okay, so histopathology. Histopathology, it's very important in central centrifugal alopecia. As we can see, premature desquamation of inner root sheath and eccentric thinning of outer root sheath. Sometimes also we can see lymphocytic proliferation around the isthmus and lower part of the infundibulum. What are the treatment? So stop traumatic hairstyling, corticosteroid, either topical or intralesional, and maintenance therapy, the use of tetracycline, such as doxycycline or minocycline, also can be used. Okay, so lichen planopilaris, again, lichen planopilaris falls under the category of lymphocytic, primary cicatricial alopecia, common in female, middle age, and Caucasian, can be associated with lichen planus, less than 30%. Usually, the exact pathophysiology behind the lichen planopilaris is related to infundibuloisthmic region of the hair follicle, which is targeted by immune-mediated lymphocytes. There are three types of lichen planopilaris. The first one is the classic lichen planopilaris. It can present with hyperthesia of the scalp associated with burning sensation and pruritus. And during the early phase, what we can notice is there is a small patch of alopecia on the vertex or the occiput associated importantly with perifollicular edema, follicular spine, and hyperkeratosis. Up to 15%, it can coexist with mucosal lichen planus. On trichoscopy, what we can see, perifollicular edema and scale. Okay, as we can see here in the picture, there is patches of alopecia with perifollicular edema and scales. And later on, there is complete scarring, as you can see here. In the trichoscopy, perifollicular scale and areas with no follicular opening, which is considered a chronic stage or later stage of lichen planopilaris. And this is the histopathology of lichen planopilaris. What we can find, importantly, dense lichenoid infiltrate at the follicular epithelium, usually at the level of infundibulum. It's important to differentiate it from the DLE, which the infiltrate will be around the isthmus. And the lichen planopilaris lack the pre-adnexal and pre-vascular inflammation. DF will show globular IgMD position and trichoscopy, as we mentioned before, in addition to white dots, which is indicate fibrosis or scarring of the hair follicle. So treatment. So the goal of treatment for patients with lichen pilaris is to reduce the pruritus and halt any further scarring. First line, hydroxychloroquine, in addition to corticosteroid. Second line that we usually use, the retinoids such as acitretin or isotretinoin. The second type from lichen planopilaris, in addition to the classic type, is the frontal fibrosing alopecia, which shares similar pathophysiology and mechanism of action. In addition to environmental factors such as leave-on cosmetic and facial sunscreen, can induce frontal fibrosing alopecia. Common in pre or post-menopausal women. It's a band-like recession of the frontotemporal hairline. And eyebrow loss usually can be found and a helpful clue. There are three clinical patterns, linear, diffuse, and pseudopharynge, which can be differentiated. We can differentiate them through the preservation of the hairline. Treatment similar to those of lichen planopilaris, but in addition, we can use or trial of finasteride or dutasteride might be beneficial. So as you can see here, the progressive hair loss along the anterior hairline with the absence of any lentigines, this is considered a diffuse pattern. And here also, one of the, this is the linear pattern. This is here we can find the eyebrow loss also. And the trichoscopy, what we all can find, absence of follicular unit and no follicular opening. The third type, it's gram-little picardilosaur syndrome. And it's only, we have to know about it, it's a triad of lichen planopilaris of the scalp, non-cicatricial alopecia of the axilla and groin, and follicular lichen planus of the body. هنا lichen planopilaris of the scalp, and scarring, non-scarring alopecia, and the follicular lichen planus of the body. Okay, let's move to the other topic. Also, it's considered the lymphocytic, which is known as discoid lupus erythematosus. Discoid lupus erythematosus is one of the entities of chronic cutaneous lupus erythematosus, which is common in female middle age. 50% from the group of chronic cutaneous lupus, but rarely develop into systemic lupus. Early lesion characterized by erythematous plaque associated with the scaling and scar and plugging. Later on, we can find central hypopigmentation surrounded by peripheral hyperpigmentation, especially in dark individuals. It commonly, of course, affects the scalp, but other patients we can experience in head and neck. Diagnosis. So through trichoscopy, what we can see is yellow dots, arborizing vessels, and fine scaling, as we can see here. And in later stage, we can observe something called milky red-white area, and with no follicular opening, as we saw in lichen planopilaris. Clinically, there is areas of hypopigmentation surrounded by area of peripheral hyperpigmentation, erythematous plaque. I think there's few scaling, and of course, scarring alopecia patch. So histopathological feature. So histopathological feature is very important to differentiate it from the lichen planopilaris. As we can see, it's a vascular interface dermatitis of the epiderm, and follicular epithelium centered around the ethmoid, and there is prevascular and pre-adnexal inflammation. We can find increased deposition of mucin and plasma cell. Regarding the DF, what we found in lichen planopilaris was deposition of IgM. In DLE, it's a full house deposition. IgM, IgG, IgA, and C3 at the basement membrane junction. And this table can show the differences between DLE and lichen planopilaris in form of histopathology. Both of them carries hyperkeratosis, pigment incontinence, while there is no mucin deposition or basement membrane thickening or lymphocyte around the adnexa or the eccrine coil that can be found here in DLE. The DLE direct immunofluorescent, it's a full house. And in lichen planopilaris, it might be negative, or there is shaggy fibrin and IgM and cystoid body formation. The scar in DLE throughout the derms, and the lichen planopilaris, it's superficial ridge, and I will show you picture now. That's the scar can be found in lichen planopilaris. It's a wedge-shaped scar and a very characteristic for lichen planopilaris. بعكس LDLE that we can find the scar all over the epidermis. So treatment, photoprotection, avoidance of sun exposure, very important in all patients with lupus erythematosus in general. But in patients with DLE, we can start with anti-malaria such as hydroxychloroquine, in addition to corticosteroid. In patients with anti-malaria resistant, MTX can be administered in addition to MMF also, which shows a promising result. Okay, alopecia mucinosa or follicular mucinosis. There are two types. The primary one, known as pincus or the follicular mucinosis or alopecia mucinosa, and urticaria-like follicular mucinosis. The secondary one, which is usually associated with the CTCL and Sézary syndrome. So the primary type, or the pincus or alopecia mucinosa, it's a benign condition. Common to be found in children and adolescents, begin as small pink papules or vesicle, collates into plaque associated with alopecia, usually found في face and scalp. In the pathology, what we can find that there is only increased deposition of mucin within hair follicle. No epidermotropism, no atypical cell can be found. Treatment, watch and wait. As it will resolve within 1 to 2 years with longitudinal follow-up, just to exclude that is not secondary and not associated with CTCL or MF. Pseudopelade of Brooke alopecia. So it's not a disease, it's rather a clinical pattern of end-stage cicatricial alopecia, most commonly seen in patients with a lichen planopilaris, which is considered the end stage of lichen planopilaris, also can be seen with DLE patient. The characteristic thing about pseudopelade of Brooke is the footprint in snow, as you can see here. It's a very characteristic feature, which known as footprint and snow, which present clinically. So let's move. So now we're done with the lymphocytic group. We will move to neutrophilic group. The neutrophilic consists of dissecting cellulitis of the scalp. So dissecting cellulitis of the scalp, commonly seen in a Black young man. It's part of a follicular occlusion triad or tetrad, in addition to acne conglobata, HS, and pilonodal sinus. It presents as firm nodules, then it will develop into interconnecting, as you can see here, channels, boggy fluctuant linear channels with purulent discharge. So the histopathology, importantly, just to know that we can see neutrophilic infiltrate around the hair follicle. Sometimes positive bacterial culture can be seen as a secondary bacterial inflammation. Treatment, isotretinoin until 4 months of achieving clinical remission. Antibiotic trial also can be given, such as doxycycline and cephalexin. TNF alpha also shows promising result, although it's not FDA approved. Laser and surgical therapy also might help. So the characteristic feature فيها انه there is interconnecting channel and boggy nodules over the entire scalp. Folliculitis decalvans. It's also common in young black men. It's associated with Staphylococcus aureus infection around 20 to 75%, and present as crusted inflammatory papulopustules, more common at the vertex, then will become rapidly cicatricial or scarring alopecia. So at the beginning, it presents as small papules associated with crustation, sometimes discharge, then become scarring. Histopathology, it's also important to notice that there is a neutrophilic infiltrate around the upper part of the hair follicle. The treatment, combination of oral clindamycin and rifampicin, a course of 10 weeks, shows clinical remission. Some patients may need maintenance therapy with oral tetracycline, and if it was resistant, TNF alpha such as adalimumab also can be used. What are the causes now? So we mentioned before the tufted hair. So these are the differential diagnoses of tufted hair. Most commonly central centrifugal alopecia, folliculitis decalvans. These all the scarring types of alopecia, in addition to pemphigus vulgaris, thermal burns, and tinea capitis. What does tufted hair means? Tufted hair or polytrachea or dull hair all are synonym for the same lesion, which mean tufting occur when infundibular epithelial of damaged follicle heal with formation of large. يعني كده بالعامي we can see this picture, multiple hair follicle arising in the same area. Oh, this is very characteristic sign we see it in trichoscopy. So lastly, the mixed type. So mixed type acne colloidalis, which is common in black, but also common in women in white. Usually acne colloidalis are related to trauma due to friction. For example, rubbing from shirt collars, helmet, heat, humidity. And some authors suggest that the presence of mast cell related to the pathophysiology of acne colloidalis. So it presents, first of all, as a smooth, firm papules, sometimes pustule, on the posterior part of the neck, at the occiput. With time, it collates into plaque or colloidal plaque that associated with the scarring alopecia, as we can see here. The histopathology, we can see mixed infiltrate of neutrophil and lymphocyte, a level of erythemas and lower infundibulum. And just not forget to mention its characteristic has loss of sebaceous gland. So the treatment. So it depends on the clinical presentation. The patient presented with non-inflamed papules and plaque, we can start with topical tretinoin or topical corticosteroid as it was daily. If the papules or plaque or pustules was inflamed, bacterial culture should be taken, oral or systemic antibiotic in addition, or a course of oral isotretinoin can be given. If the plaque was less than 1.5 centimeter, excision with primary closure should be done. If the plaque was more than 1.5 centimeter, excision with horizontal ellipse, the excision should extend into deep subcutaneous tissue and allows to heal by secondary intention. But don't forget, don't inject any corticosteroid into the post-op site. Post-operative care, some researchers suggest use of imicamode for 6 weeks. And as a maintenance therapy, topical tretinoin with intralesional steroid or oral antibiotic when needed can be used. Erosive posterior dermatosis with the scalp, one of the inflammatory disease that occur primarily over the photo-damaged scalp. Present with sterile pustules, erosions, and crustation, especially over the patients who has sun damaged scalp or fair skin, who usually exposed to the sun frequently. Treatment are usually class 1 or class 2 corticosteroid, and sometimes oral isotretinoin also can be used. Acne necrotica, usually the mechanism or the pathophysiology behind acne necrotica is not very known, but it begin as papule or vesicle, and then over the time become hemorrhagic and eventually devolve veriform scar. So the differential diagnosis can include molluscum contagiosum, herpes zoster, eczema herpeticum, which mainly related to especially if it's presented in a later stage. Treatment we can say it's a little bit resistant to treatment, but long-term use of antibiotic or isotretinoin is recommended, especially if we combine it with corticosteroid, it would be better. So finally, now we are done with hair loss disorder. This is a summary of what we mentioned from scarring and non-scarring type. So to summarize, non-scarring alopecia, we have androgenetic alopecia, telogen effluvium, alopecia areata, trichotillomania, anagen effluvium, traction alopecia, temporal triangular pressure-induced, and lipodermatous scalp alopecia. So androgenetic alopecia, as we mentioned, genetic, WNT and androgen receptor. Pathogenesis, there is increased dihydrotestosterone, lead to ministerization of the hair follicle. A pattern, male and female. Treatment mainly minoxidil, finasteride, and dutasteride. Telogen effluvium, multiple trigger, lead to hair shedding after 3 months. One of the very common triggers is when the ferritin is below 40. So treatment, correct the cause, iron replacement, and reassurance. Alopecia areata, autoimmune mediated disease, usually associated with atopy, thyroid, vitiligo, SLE. Patterns either patchy, ophiasis, sisafo, reticular, totalis, and universalis. Nail finding, which is very important, pitting and trachonicia. Poor prognostic factor if it was childhood, chronic, ophiasis, nails. Treatment, topical or intralesional steroid, immunotherapy, systemic steroid, MTX, and most importantly, JAK inhibitor. Trichotillomania, it's an OCD spectrum, irregular patch with hair different lengths. Trichoscopy sign that we mentioned that يعني هذه هنا 3 but what we mentioned that is very specific to trichotillomania was 7. Treatment, cognitive behavioral therapy, clomipramine and SSRI. Anagen effluvium, there is sudden loss of the hair, usually 2 weeks after the onset, related to chemo, radiation, and toxin. Broken hair, Paul Pincus construction and trichoscopy, very important. Remove the trigger and scalp cooling during chemotherapy. Traction alopecia, tight hairstyles, usually in frontal and temporal. Don't forget the French sign. Treatment, stop the traction, minoxidil, intralesional steroid. Temporal triangular alopecia, it's congenital, found in early childhood, persistent, and what we can find also it's a vellus hair. Treatment, no treatment for temporal triangular alopecia except for hair transplant. As I mentioned, it's persistent. Pressure-induced alopecia, usually post-surgery in ICU, and it's reversible. And a lipodermatous scalp alopecia, as we mentioned, it's a thick, spongy scalp related to lymphatic dilatation. Treatment, steroid and MMF. Okay, so this is also a summary of the scarring or cicatricial alopecia. Generally, it's a permanent follicle destruction, usually at the bulge stem cell. It's primary or secondary. How to diagnose? Dermoscopy and biopsy, horizontal and vertical. Lymphocytic, LPP, central centrifugal alopecia, and DLE. LPP, the classic perifollicular erythema and tubular scale, frontal fibrosing alopecia with eyebrow loss as a clue, and gram-little Picardy syndrome, which is triad. Don't forget the triad. Treatment, hydroxychloroquine, doxycycline, steroid, retinoids, MTX, and all of these. CCA, commonly in the vertex and move centrifugally, more common in Black females. with PADI3 mutation, very important mutation. We can see hair tufting, and we discussed previously differential diagnosis of hair tuft. Treatment, steroid, doxyhydroxychloroquine, avoid traction, and chemical. Daily, erythema scale follicular plugging is also mentioned. Trichoscopy, you can find yellow dots and arborizing vessels. DIF full house, بعكس lichen planopilaris, which was cystoid bodies, shaggy fibrin deposition on IgM. Photoprotection, hydroxychloroquine, steroid, and immunosuppressant. Neutrophilic, we have the dissecting cellulitis of the scalp, folliculitis decalvin, and dissecting cellulitis and folliculitis decalvin. So it's a boggy nodules, as you remember, then it will rapidly convert into sinus tract associated with follicular occlusion tetrad, acne conglobata, pilonidal sinus, and HS. Treatment would be isotretinoin, antibiotic, TNF-alpha inhibitor. Folliculitis decalvin, mainly associated around 75% with the staph aureus. Tufted hair also can be found, and a course of antibiotic of 10 weeks from clindamycin and rifampicin can be used. The mixed type, which is the acne acylidales nuki, erosive pustular, and acne necrotica. Acne acylidales nuki, usually commonly in the occipital part of the scalp, start at the neck papule, then rapidly it turns into colloidal plaque. Treatment, steroid, antibiotic, retinoid, and even TNF-alpha can be used. Erosive pustular dermatosis, usually in elderly, photo-damaged scalp or skin. Acne necrotic, it's umbilicated papule, which turns into varicose scar. Important to know the differential diagnosis of acne necrotica, including molluscum contagiosum, herpes zoster, and eczema herpetica. Other pseudopelade of Brugge, as I mentioned, it's not a disease, it's an entity. Usually, most common, it's a chronic phase of lichen planopilaris and DLE. The characteristic that we can find is the footprint snow. إذا فاكرين الصورة اللي وريتكم هي. Follicular mucinosis, primary versus MF associated. So it's important for the primary to watchful waiting and check the patient as it could be an early stage of MF, although the primary one, it's not associated with any epidermotropism or anything. Okay, so let's now start with the nails disorder. So in the beginning, also we have to know the exact nail anatomy. As you can see here in the picture, sorry. Okay, there is the free edge of the nail, the hyponychium, the onychodermal band. ما أدري إذا واضح عندكم أو لا. This is the nail plate. This is the lateral nail fold. This is the proximal nail fold. This is what we call the lunula and the eponychium. Another picture. نفس اللي قلنا اللونيلا هنا proximal nail fold, الeponychium, lateral nail fold. This is the onychonerval band, the pinkish line, at the distal or free nail edge. More into details or deep wise, this is the eponychium. This is the distal nail matrix. This is the proximal nail matrix that we call it nail bed, which is underneath the nail plate, and this is the hyponychium. Why we're mentioning all of these? Because nail disorders related to nails anatomy. So correlation of nail finding with anatomic site of nail damage. If the proximal matrix was affected, booz line, pitting, ridging, fishing, trachonychia is the finding. If the distal nail matrix affected, we can find true leuconychia. If the proximal and distal, we can find onychomediasis, colonychia, and nail thinning. And also, if the nail disorders, nail bed was affected, we can find onycholysis, subungual hyperkeratosis, apparent leukonychia, and splinter hemorrhage. Let's start with the proximal nail matrix. So as we can see here, if we want to describe it, there is like a line in the middle of the nail that's known as booz line. So booz line is a disorder of proximal matrix. There is a temporary interruption of the mitotic activity. The depth of the depression indicates the extent of the damage. The width indicate the duration of the insult. Most commonly result from what? From mechanical trauma such as manicure, pedicure, onychotilomania, sometimes related to dermatological disorders such as eczema. If multiple lines indicating repeating damage, it can suggest there is a systemic cause such as febrile illness, erythroderma, or a chemotherapy. Okay, so this is another nail disorder as you can see here, which is known as onychomediasis, also related to proximal matrix. The cause of onychomediasis are the same of bruise line, but if the involvement of multiple digits suggests a systemic cause, most importantly, Kawasaki disease, hand-foot-mouth disease, and measles. Usually, it develops weeks after the onset of disease, especially a viral infection. Okay, third one, as you can see here, it's obvious here, it's nail pitting. So it's also related to proximal matrix. It's depression or punctate depression over the nail plate. If you remember, we mentioned before that in patients with alopecia areata, the most common nail finding is nail pitting. So it's important to differentiate the nail pitting and alopecia areata from those and psoriasis, where alopecia areata is geometric and regular and superficial. In patients with psoriasis, is more irregular and deep. This is also another nail finding. As you can see here, it's bridging and fissuring. So it's known as onychorexis, a thinning of the nail plate related to proximal matrix disorder, bridging and fissuring. Can be found like in planus, trauma, and tumor, but it's not specific. Or also can be found as a sign of aging. As you also can see here, this is known as trachonychia or 20 nail dystrophy or sandpaper nail, or all of them are synonym. So it's known as also a nail roughness, related to proximal matrix disorder, common in children, and it can be associated with other diseases such as alopecia areata, lichen planus, and eczema, but also it's not specific. No exact treatment or no effective treatment, as it can regress spontaneously. Okay, so this is like white lines over the fingers, so known as leukonychia. We have two types of leukonychia, the true leukonychia and apparent leukonychia. The true leukonychia is different from apparent leukonychia, as the origin of the disorder is different. True leukonychia related to distal matrix disorder, while apparent leukonychia related to nail bed disorder. Okay, so true leukonychia, it has three types. The punctate, which is most commonly caused by trauma. Straight, one of the straight subdivided into meseline, which is caused by arsenic or thallium poisoning, and diffuse, which is associated with syndrome. The differences between true leukonychia and apparent leukonychia does not disappear with the pressure. When you press over the nail, it will stay. The axial apparent leukonychia, when you press, it will fade away. Okay. عندنا الكويلونيكيا, which is related to proximal and distal matrix. It's like a spooning of the nail, as you can see here هنا أوضح في الصورة. More common to be seen in children, and in adult can be associated with iron deficiency. Okay, so this is an obvious brown longitudinal line, which is known as longitudinal melanonychia. So it's also related to proximal and distal matrix. If it was a single band, it can be related to nail melanoma. Commonly seen in dark pigmented individual. It can be associated with medications such as azathioprine, hydroxyurea, zidovudine, chemotherapy. And also it can be a sign of melanoma, as I mentioned, if it was a single band. These are the causes of longitudinal melanonychia: trauma, manicure, onychotilomania, medication, as I mentioned, and just remind zidovudine, which is a high yield for exam questions. This is the Hutchinson sign, which it's a specific or a sign that we usually see in patients of nail melanoma. حطيت الصورة بس عشان to know the differences between what Hutchinson sign, which affect the proximal and lateral nail fold, and what's longitudinal leukonychia over the nail plate. Okay, so that's the apparent leukonychia. So apparent leukonychia related to nail bed. Nail bed edema, white color that fades when you press over the nail. بعكس true leukonychia, which stays when you press over the nail. There are 3 types of apparent leukonychia. We have the Merck nails, which associated with chronic hypoalbuminemia. It's a transverse white band parallel للونيلة. هنا اللونيلة فيها parallel. The teres nails, leukonychia of most of the nail plate associated with liver cirrhosis commonly. Half and half nails, which usually are related to renal disease. And this is the true leukonychia or total leukonychia. Onycholysis, it's also related to nail bed. It's a detachment of the nail. The causes, it's not specific, could be related to trauma, any dermatological disease, even thyroid disease, pregnancy, and medication. Okay, this is what we known as oil spot or salmon patch, which is highly specific for patients with psoriasis, which reflect the exocytosis of leukocyte beneath nail plate. So important any psoriasis patient to check the nails and to check the specific signs, especially the pitting, oil spot, and salmon patch. These are the splinter hemorrhage, which also related to nail bed. Splinter hemorrhage, there are 2 types. If it was distal or proximal. Distal could be associated with the trauma or psoriasis, and if it was proximal, mainly related to endocarditis and vasculitis. Okay, this is also known as hepatic deformity, usually related to those who usually use nickel nail biting, associated with an anxiety disorder or OCD. And it's reversible, but sometimes it takes long time until it be reversed. This is the subungual hematoma, as you can see here, most commonly related to trauma. Trephination of the nail needed if it was more than 50%. And if it was associated with a fractured distal phalanx, X-ray should be recommended. Okay, this is also a very interesting nail disorder. As we can see, this is the dorsal petragium and this is the ventral petragium. It's important to keep in mind and to memorize what is associated dorsal and what is associated with the ventral. Dorsal usually related to lichen planus, GVHD, and 10. The ventral one associated with connective tissue disease and systemic scleroderma. Ventral means from the backside. Okay, so this is the summary about the nail disorder. As we mentioned, proximal matrix disorder, Bowes line, onychomadesis, pitting, rixus, onychorexis, and trachonychia. While distal matrix, we have the true leukonychia and 3 subtype, punctate, straight, and diffuse or total. Proximal distal matrix, we have the koilonychia, spooning of the nail. It could be physiologic in children or related to iron deficiency in adult. Longitudinal melanocytia related drug, race, and melanoma if it was single band. Nail bed disorder, apparent leukonychia, the murky, teary, and half, onycholysis, oil spot, salmon patch, splinter hemorrhage. Other hepatic deformity, subungual hematoma, petragium, is either a dorsal or ventral, and Hutchinson sign, which is sign of melanoma and required nail biopsy. I think I'm done now. If you have any question, you're most welcome.
Thank you very much, Dr. Rahaf, for joining us today. It's our pleasure and honor to have you with us. يعطيك العافية. المحاضرة كانت قيمة.